What we're going to do is try and structure it through the way that you would see it. So we're going to talk about all aspects of it: anatomy, risk factors, biomechanics, diagnoses, blood supply, debate, and there's a reason I've said debate, non-weight bearing protocols, surgery versus non-surgery, imaging, and management.
How long we got?
Yeah, I reckon we get this down in about 40 minutes.
40 minutes?
40 minutes. But it's interesting, and I'm going to tell you something about this podcast, the Sports Medicine Project Season 2 with Blake and Kelly. There is no resource that I could find in podcast format that is directly focused on navicular stress fractures. I can't find it. And these little fiddly weird things, like that was the motivation for the Liz Frank podcast with Professor Martin Sullivan, which was 2 episodes ago. I mean, that podcast was really popular because like you can't find these resources. I mean, you can find them at courses, but you just don't.
I also feel like we've been on the lookout to have someone on the podcast to talk about navicular stress fractures for a while. And
then you realise that you already know him.
That he's right
there. I eat dinner with him every night.
I said, I'm going to interview you. Yeah. Let's do it.
All right, let's start some facts. Let's boost the engagement. So, Town et al., 1970. So not that long ago, it's at 54 years, the first description of a navicular stress fracture. Now, I'm going to abbreviate it to NSF. Because
I don't like it.
I've got to, because I'm just going to be saying it too much.
But you'll say NSS, FFS. Now remember, that's a navicular.
Yeah, I'm going to call it NSF.
Just say navicular. It takes 1 second.
Yeah, all right. I'll just call him navicular stress or something like that. So, first described, 1970.
Navicky stressy.
Now, Latin, and I'm big into Latin now, guys, because I've been to recently around Greece and learning about Greek mythology and language. And at the moment, if I look up, I'm looking at 3 little sculptures of Aristotle, Socrates and Plato.
I was wondering if they were going to come
up
today.
They were going to come up. They're great thinkers. You might even say that you're listening to the 2024 version of them. No, I'm not kidding. I'm nowhere like Plato. You're a little bit more like... It was Medusa, wasn't it?
Medusa?
Who's the one you say you were?
Athena?
Athena, that's right. Athena. Yeah. Athena. Latin word for navicular. A vicularis, meaning boat-like. Isn't that interesting? So I thought that was cool. Now, navicular stress account for approximately 1/3 of all stress fractures of the lower extremities, but 98% occur in athletes. Males, 20s. They're basically the 3 things. If someone comes in and they're a male and they're in their 20s, they're an athlete and they play any of the jumping sports which we're going to talk about, and they have diffuse midfoot pain, that's more than enough. But interesting, because female is obviously an independent risk factor, significant one for stress fractures, but males in their 20s are the most likely cohort to suffer with this.
Did you say 98% are athletes, or 98% is what you described?
No, 98% occur in athletes.
Well, what bone stress injury wouldn't occur in an athlete?
Yeah,
apart from it's like a deficiency fracture, but
yeah. There's more nuance to that conversation, but for this type, because the biomechanics and the way the navicular is in the foot, the jumping explosive sports, which obviously is correlated well with athletic sports, it's just going to put it under more stress. But at 98%, that's a huge one, and that's an approximate.
Because that's not surprising to me.
Yeah. Still, it's a high number.
Like, does a sedentary person ever walk into your office and you think that they're dealing with a navicular bone stress injury?
No, I just think 98% is a high number.
It is a high number. That is correct, but it's not surprising.
So,
carrying on.
No, you're right. It's a very high number. Not surprising to you. Surprising for me, but it doesn't take much to surprise me these days. So, yeah, mostly young males. The approximate number, reading somewhere between 1/3 of all foot and ankle, 1/3 of all stress fractures of the lower limb. Some say up to 35% of all foot and ankle stress fractures occur in the navicular. But in my clinical practice, I wouldn't see that number as high. That it's a lot more metatarsals and tibia. But I guess that doesn't include the foot and the ankle. The average duration of symptoms, and this is Sexana et al., which their study is in the show notes, 8.8 months in some cases. And I've read that as low as 4 and as high as in this 8.8 to a definite treatment was initiated. Isn't that such a long time?
It is a long time.
And for such a serious injury.
Yeah, it's
I
crazy.
just couldn't believe that. So, just speaking, what about in your clinical practice? How many Naviculars? You see them often?
No, you know what? There's this one person that I think about regularly, and it fits that entire description that you just mentioned of who is most at risk of developing a navicular stress fracture. And I remember palpating right on the navicular, and it was sore there. They were getting night pain, work, like all the typical signs of a bone stress injury. And I tried to get them in to see the sports doctor, but they didn't want to wait that long to get there. So they just decided to get an MRI. They ended up going to their GP to get an MRI.
Yeah.
And it came up as clear. And they just self-managed. They were like, oh, it's all clear. It's not that. So I'm just going to manage it. And I just never saw them again. And it just annoys me to this day because I'm like, I'm certain that there was still a navicular stress fracture in there.
Yeah. Well, we're going to talk about imaging, and in those cases, up to 71% can be missed with MRI. That's only based off
Its anatomy.
Yeah. I mean, people say it's shaped like a bone. I don't really.
I mean, it's an irregular bone, isn't it? Is that the description of that type of bone?
Yeah. Yeah.
So it's a boat-shaped irregular bone.
But I'm not going to talk about it like a boat. Let's move on.
Let's
from
talk
the boat
about
stuff.
it like a navicular.
Yeah. That's a good plan for this podcast on the navicular stress fractures. All right. So, if I want to describe the anatomy, is if you are able to think, kind of visualize it in your mind, if you see it on the internet, and if you go to my LinkedIn or Instagram, there's some pictures of it. But the way to think of it and the way we're going to talk about it is from different angles. So we can have looking from the rear foot or the calcaneus through the foot, looking from the front and looking from the side. So if you're looking from the back of the foot where the calcaneus sits and going through, you've got the proximal surface, and that's all covered with articular cartilage, and it is what they call, which I learned, I would always just call it concave, but it's called bioconcave, which just means it goes in like you're walking into a cave, and the other side, which is the distal part, is convex or bioconvex, and the top, the dorsal, is bioconvex as well. And an easy way to think of it, if you have, let's say, a ball of Play-Doh, and you push your fist into the Play-Doh, when your fist touches that Play-Doh, it's going to go around there, and if you remove it, what was in contact with the Play-Doh, that would be concave, and on the other side, it would be convex. So that's the easiest way to think of it, and then you kind of turn it on its head and turn it on the side. So it's really important to think of the anatomy, because when we start to talk about the biomechanics, why they can be a real pain to treat and take a really long time, that has a huge effect. Does that make sense? Play-Doh analogy?
I've always thought of concave as being like a cave, so it's inside. So that's what helps me remember it. But the Play-Doh works well too.
Play-Doh works too. Right, distal surface articulates with the three cuneiforms, medial, intermedial, and lateral, and then you've got, in some cases, and when I was reading, there's some differentiating anatomy, which is the case with everything in the body, but there's some differentiating anatomy of if it articulates with the cuboid. But we're just going to speak proximal, distal, and the dorsal. The plantar surface is concave as well, and it sits, when you look at it on a foot, it just sits in the middle, so it's kind of wedged between everything.
Yeah, it's just kind of a space filler.
Yeah,
isn't it? Amongst all the, I suppose they all are, but they all just fit together, don't they?
And when they come into the clinic, it's you can palpate the navicular pretty easily, and you don't have a lot of anatomical structures around it. I mean, you've got the tib post on the medial side, and I was thinking, before recording this, if that would change, if someone has an accessory navicular, would that change some of the force distribution? Because there was a study from Tusada et al. Saying that 21% of people have an accessory navicular, and I don't know how much that would change. I'm assuming it would be less force, because that has implications for stress on the bone as well. And then plantally, you've got the plantar calcaneal spring ligament attaching there, which obviously, if foot type comes into it, which we will talk about, that's going to have some implication. If someone has quicker pronation or a higher end range, you can have a bit more strain on that plantar ligament. So that's the anatomy.
And then in terms of, are you going to talk about biomechanics?
Oh yeah, we're going to.
Later or now? Because I've got a question.
Yeah, hit me with it.
So my understanding of why the navicular is a little bit more unique, given its shape and its positioning, is that the loads that are applied to the navicular is more of like a compressive type of load. So it's load that's going from, that's like squishing it together almost.
Yeah.
And that's what is creating that excess stress that can lead to stress fractures or bone stress injuries. Is that accurate?
Yeah, the whole foot from a recent paper which is called Chasing Footprints in Time, but that paper kind of accumulated all the theories we have on how the foot works, and it was really quite eye-opening in the podiatry world and the biomechanics world. So a lot of the theories previously we thought about the foot, how it being really mobile and a rigid lever, played into a lot of how we thought stress was applied to the foot, because we know there's some areas that are under higher and less stress. So I can't really speak exactly what is saying within each foot because there's big variation and there's some compelling theories out through there. But what I can say, I mean, pretty convincingly, I think we're going to have some degree, of course, of subtalar joint pronation. So the subtalar joint comes in and the mid-tarsal joint is going to supinate, and we're going to get some stiffening of the foot. Now, it's probably less stiffening than what we thought, but we're going to get some stiffening, some pliability in the foot. And it has to be, because it's going to be able to hold our body weight if we're running and walking and jumping forward. So when the foot, let's just say, is stiffer, as we spoke about with the anatomy, you're going to have a lot of force around the navicular applied. And because you've got so many articulating surfaces, plus the spring ligament underneath and the tip post, it really does get pulled apart and over. So we think of that shape that we spoke about before. On top, if you're getting it pulled round and down as the weight's coming through, you're going to get, in some cases when it's trying to heal, bone being pulled apart, but you're going to get quite a significant amount of force through that part, on that tensile force in through the top of the bone. So you imagine if they do break down, bone cells are trying to come together, and every time you do something, you're pulling them apart. So that's why they have to be, which we'll talk about, non-weight bearing for 6 weeks, because any load applied to the foot at mid-stand is going to pull that apart. Yeah.
I think I was meaning more so compressive force, as in like the talus is sort of getting, and maybe it's in that situation where the foot is stiffening, the talus is actually pushing towards the navicular. Yeah,
because the talus is, the navicular is between the talus and the cuneiform.
Yeah.
And the navicular transmits force from the first and second metatarsal cuneiform, like during foot strikes. So you see a force transmission in through there. And because the tenonavicular joint gives the foot a lot of mobility, you're going to have force through the talus gets transmitted to the navicular, and you've got to have a pretty stable forefoot, which is pivoted on the ground. So you're going to have some twisting and kind of torsional forces into the navicular. And it's in the middle. Like it's the one that really is under force all the time. When we look at some of the other biomechanical, anatomical risk factors,
it's like a load distributor, but everything's got to go through it.
Having your forefoot adducted are going to put a bit more force into that navicular. And of course, the tip post, I mean, that's a pretty powerful plantar flexor, more powerful inverter and plantar flexor. That's going to apply some force to there as well.
Yeah, okay.
Yeah.
And so then does that tie into risk factors as well? Like, for example, like is an accessory navicular a risk factor, or do biomechanics predispose someone to developing a navicular bone stress injury?
Yeah, the risk factors are tricky because what we can say, certainly if you've had a previous stress fracture somewhere in the body, in the lower limb, you're going to be at a higher risk of having one again. We know that pretty convincingly. There was one military study where they looked at people who had a previous navicular one. Their risk is going to be higher again than if you've had a previous one.
In a navicular again.
Yeah, in the navicular again. So as I said, young males, definitely, if you're playing sports that are explosive, basketball is really high, middle distance running where, you're running...
Up on your forefoot.
Yeah, you're running on your forefoot and you're running pretty quick and for longer. And I reckon that the middle distance people can run at a higher intensity, or potentially their week is, as a percentage, a little bit higher. So they might do, say, a marathon runner, 20% of their week is at a higher intensity. For a middle distance runner, it might be 30 or 40 because they're doing overall less volume, but a bit more intensity to stay sharper.
But then their volume is still high.
Yeah, well, yeah.
That's a good point.
Yeah, so they're the ones, I mean, they come in and they're doing that and they've got diffuse, midfoot pain, you've got to be concerned with that. But they're the ones that have been mostly identified in the research. And then also bone morphology. We know genetics plays a big role in any stress fracture, purely just some people have smaller bones. But for the navicular, if we're thinking about the shape and size, if it's thicker or it's rounder, it's going to be able to tolerate and transmit more force. So the morphology of the bone, which there is big variation in the actual shape of the bone, and there's big variation in the blood supply, which we're going to talk about. So that has to be a risk factor. But obviously you can't speak to people about that. It's just going to be the case.
And so do you have any insight into why females are less likely to develop a navicular bone stress injury?
I don't know, maybe the sport. I think maybe I would assume that more males play things like basketball, because I mean I keep saying basketball, but that's the one where it's been reported on the most. I don't know about the running if middle distance is more common in males, but yeah, I don't know the reason for that. Potentially other bones break down first. I don't know.
Yeah, I don't know either.
Yeah.
I wonder if it has, I was just thinking if it had anything to do with, similar to like a patella tendinopathy, where you almost have to be strong enough to put a particular type of load onto that area. I wonder if there could be anything like that in the navicular, but I guess it would be all relative. So
Yeah.
it wouldn't, I suppose females are more likely to get majority of bone stress injuries, but it's just interesting that the navicular is so uniquely biased towards males.
Yeah. Yeah. Some other biomechanical anatomical risk factors, a metatarsus adductus, which where the forefoot comes in relation to the midfoot. But you know, I couldn't find any force data to theorize how that would increase the force through there. But I was thinking, you know, potentially with a medial transfer of the force through the forefoot, the midfoot might be under more stress rather than going through the whole of the forefoot because it's going to be adducted. Maybe so the navicular is kind of the last stop and cop some of that force. Yeah, but I couldn't find any force data to say how that changed. Reduced ankle dorsiflexion, limited subtalar joint range, which makes sense if the subtalar joint's a little bit stiffer. Generally, the force is going to be transmitted to the next proximal joint, which is going to be around the T and J and the navicular. Short first met and long second metatarsal. I think the longer second met, we know that's a risk factor for second met stresses, but potentially, you know, if the second toe is bending up more force through the second met to the cuneiform to the navicular, it's kind of a bit more in line. And a lot of these things you can't change.
I was going to say, it's
anyway,
like the only clinical relevance I can see for this is if someone comes into the clinic and they're like, I really just want to try to do everything I can to avoid a navicular bone stress injury. And you're like, okay, well, let's work on your ankle dorsiflexion then.
Yeah, how much are you going to get there? And how much is that going to move
Or
the
I
needle?
guess if it's, or if someone's already had it, is that something that you focus on during your rehab to try and minimize the risk of it happening again if it is more likely for it to happen in the navicular again? So I guess they're just the hanging fruits that you could pick away at, but yeah, you're right. How much of an influence would it have? Don't know.
Yeah, there was one study from Becker et al. Which compared the foot kinematics between runners and non-runners and looked at people that had a navicular, you know, what did they have going on with the way that they move, decreased plantar flexion range of motion, greater hindfoot eversion, which is just the rear foot rolling in, and reduced forefoot abduction excursion, which is kind of the end range of the forefoot coming in. And they concluded that ultimately an inflexible foot may predispose to these injuries due to increased stress across the navicular. So what I take from all this kind of kinematic research is it seems to be potentially an inherent sweet spot of the pliability of the foot, which kind of is stiffness, where, you know, a foot that's too stiff seems to have higher forces, and a foot that's really flexible seems to have higher forces as well, because previously thought with biomechanics, if you pronate, if your subtalar don't pronate quite a lot, your T&J or your midfoot really struggles to supinate and get into a nice foot position, and you kind of see that with people that have adult acquired flat foot, where you give them an orthotic and their foot really does function a lot better, and they're a lot more fluent through a gait. And if they're really pronating through the subtalar joint, you're going to see a lot of force through the navicular. So it's kind of this flexible, non-flexible, and somewhere in the middle potentially. But again, can't really change it. You can influence it a little bit, maybe with some offloading stuff, but you know that doesn't move the needle that much.
And you probably wouldn't influence that until after. Like, it wouldn't be something you could do preventatively.
No, but in saying that, so one military study gave people custom foot orthoses and found that it did reduce the incidence of stress fractures.
Before they'd ever had one before?
Yeah, and that was an RCT. So that reduced the incidence of, although it was lower limb stress fractures, but reduced that incidence. But again, does that mean that everyone with a bit stiffer or less stiff, or, you know, they're going to be doing more training, could use a foot orthoses? I'm not against it. Like, if you had a group of people that are going to train hard for 6 weeks, trying to think of the potential harm. I mean,
I guess it's moving load around into an area that the body might not be able to deal with. And so if you gradually ease someone into the orthotic, which I'm assuming you would, then I couldn't see the harm either. Apart from them thinking that they need to wear an orthotic for reasons.
Because it's not going to... I mean, we've spoken about you can't take all the load away, but from what we're learning about bones, if muscle contraction is the big factor, and you give someone a foot orthosis, they're not going to have to contract their muscles as hard because the foot orthoses are going to be doing a little bit of work for them. So let's say my arch is flattening and all the muscles that control that motion are going to have to work really hard. Typical, normal. If I put a foot orthosis under there, I mean, you're going to theorise and tell me if you agree or disagree that they're not going to have to contract as hard because the orthotic is providing some stiffness to the joints. So, of course, it's going to reduce stress on the bone. But then where does that go? Does it go more proximally?
Well, it has to.
Why would it?
Because it can't just disappear, can it? Like if you're running 5-minute Ks without an orthotic and then you're running 5-minute Ks with an orthotic, that load is still going through your foot. It's just not being applied.
I'm assuming some that's going through the foot orthosis. Because, I mean, I know you can't take energy away. This is getting into physics, but you can transfer energy.
But so it's getting transferred somewhere else in the body.
Can it not be transferred to the foot orthosis?
I don't think so.
That would be an interesting study.
Because we'll think about super shoes. The forces don't go away.
No, that's...
What's the difference? It just gets moved.
Yeah. I don't know if it's the same analogy. So you're saying that you're going to have more hip flexion when you're wearing a foot orthosis? No,
but if you're trying to minimise the load like medially, then it might just be shifting more laterally.
Yeah. Yeah, potentially. That's a really good one to think about. I want to think about that a little bit more. Yeah. But risk factors, not that much. Of course, all the other bone risk factors, hormonal stuff, RED-S, that kind of thing, previous big increases in training load, all that type of stuff is all relevant, but specific to naviculars is a little bit different.
And then biomechanically, we spoke about that a little bit just before, but is there anything else in the way of biomechanics that is uniquely relevant to the navicular?
Not really, other than what we spoke about. Like that's kind of the crux of it. And I don't really know if understanding it that much more is going to yield that much more benefit because we know everyone's going to be individual. And the biomechanics, plays a bit of a role in it. I guess it gives you more justification because for orthotics and shoes that are going to probably do the same thing. I mean, shoes with a higher pitch and shoes that may be a little bit wider and have a wider geometry with the foot orthosis in there. And as we're going to speak about, people can have pain for a long time. Most people get back to activity. I think it's about 98%. But could that be a little bit better with a foot orthosis? That would be a really cool study to do, to have people kind of foot orthoses first on and just see if they get back quicker and if they report feeling a bit more comfortable. Because the ones that I've seen, it makes so much sense. Because foot orthoses generate they generate a supinatory force under the area of the navicular, basically.
Blake, look that up.
No, you can say it when you look at me. But that would take a while to look up. So, yeah.
So then how are you diagnosing these injuries? So is it often the case where patients are coming in, they've got pain over that medial aspect of their midfoot, and they're male, they play sport, they've had an increase in their training load? Like what sort of questions are you asking, and then what assessments are you doing? Yeah.
So with bone stress, I think my threshold is a little bit lower, certainly for imaging, just because of the consequences of these ones, and because the research just suggests that the time to diagnosis is so long, like we spoke about, it'd be 8.8 months, or the initiation of treatment. So there aren't many things in the midfoot. I think in my clinical head, if someone comes in with diffuse midfoot pain, the things that I want to rule out, if that's all they told me, said, I have midfoot pain. Let's say they put that on their new patient form. I want to rule out and make sure it's not a Liz Frank. And I want to make sure that it's not a navicular bone stress, because they're pretty serious ones. And we've got some pretty clearish tests to be able to think, all right, we need to investigate this further. But the real ones are going to be, potentially a male in their 20s. Almost always there's an increase in training load quite quickly, and that can be not just running and jumping, but they might have kept their running load the same. They might just be walking more. They might have got a new dog and they're walking the dog more, or they're doing something more on their feet, or they just started, in addition to their running, started playing basketball or volleyball. So that's what I'm looking for. And if they have pain around or at the navicular, all the research suggests that it's really diffuse. So they'll just kind of say it's in this area on the midfoot. And there's not a lot there. I mean, unlikely to have like a T-band tenosynovitis, it's not going to be midfoot away. They might have a joint injury, but, you're going to be pretty well able to palpate that navicular. The end spot's reported between, the dorsal middle of that part. And then, of course, hopping. They did report in the literature that you can abduct the forefoot on the midfoot, but I've never done that to see it to be positive. And I guess that just puts a bit more stress on the navicular. But vague midfoot pain in someone that's increased their training load and pain to hop and they're pointing at the navicular, you've got to be concerned.
I always find it interesting when you say that there's not much else there, because I find the foot to be quite a convoluted area where there is a lot of things overlapping one another.
Yeah, tricky old thing, the foot. Well, you're looking at my foot now. When you think of the anatomy, and I teach the students to think kind of from superficial to deep, what it could be, and then when you hear trampling, no, when you hear running, hooves. What's the one where you hear something, think horses, not zebras?
Oh, yeah.
I think I don't know if I say trampling because that's like killing people. When you hear
Stampede.
Maybe when you hear a stampede, that's definitely wrong. I think horses, not zebras. So then you just think of the most common things and about that person, and that's why the incident research is cool, because you sometimes think,
I don't like that though.
What do you mean?
I don't like it when people talk about like statistical likelihood of it being one thing versus another, because
But it gives you another data point.
it does, but there is still the chance that it could be a zebra. And I just don't think it's helpful, because there is always a chance that it's going to be the 1% weird thing.
But we have the data to say, if you were to compare them, it is, and if you look at it in isolation, yes, I'm saying that you shouldn't just base the statistical stuff, but it is another data point that does move the needle a little bit. Someone comes in, a 75-year-old female with midfoot pain.
You're thinking more OA.
Yeah, because of their age,
Yeah.
and a little bit about what we know, the incidents and things. So I think there's a little bit of value in it, but I'm happy to be wrong on that.
I guess you're right. I guess that's something that you just do inherently without even thinking about it. Sometimes I get frustrated with that statement because I don't feel like it's always that helpful, because there is always the chance that it could be the other weird thing.
Yeah, you're right. And as you said, in isolation, it's not going to give you that much value. And you obviously pair it with your clinical stuff.
Yeah.
But for me, in that area, there's, like, you got the tendinonavicular joint, you've got the tib post, but that's on the inside. Over the top, you've got, your extensor tendons, the tibant, the joint capsule, and the bone. And as you said, if someone's got pain there, with some of these other things that were spoken about, it's like, well, that's enough.
Why do you say that it's not a tibant tendon?
Well, how often would you see, and this is again using incidence, how often is it reported, and do you see a tibant tendinopathy or a tibant tenosynovitis?
I feel like that's not any more or less common than a navicular bone stress injury. Do you think?
I think the navicular is more common.
Maybe that's just what you're seeing.
Yeah. How much literature have you read on tibant tendinopathy?
Not much off the cuff right now, but I do think it's a possibility that could
Blake, look that up.
Blake, look that up. I don't think that that's a unusual presentation or diagnosis, or more like a tenosynovitis, I think.
Yeah, I've seen like 2 in the last couple of years. Yeah, maybe you're just a tibant girl.
Maybe.
Yeah. Okay, well...
But like someone who's been doing a lot of uphill walking or doing a lot of stair stuff, like things that are that repeated dorsiflexion, where they get that shearing of the tibant tendon on their shoes or having their shoelaces too tight. I think that is something to develop a tenosynovitis.
So I said, if they've got this midfoot pain paired with what was spoken about. So if someone comes in and they're a male in their 20s playing basketball or running, and then they have pain on the top, are you still thinking, what are you thinking?
Well, I'd want to rule out a navicular bone stress injury.
And what do you think it's probably most likely to be?
I guess it could still,
it could be, yeah.
You've set me up that I'd say yes, but I don't think that you could...
Yeah, it's probably not a fair question.
You would always want to rule out the navicular bone stress injury just based on the risk of missing it. But I think it's a possibility that it could also be a tibant tendon or tenosynovitis or tendinopathy.
Yeah, let me just try and bowl you out with this one. If we think of like sports that are high tendon loads, Is walking a high tendon load for the tib ant?
No.
What is high tendon load for the tib ant?
Doing
Bowl.
heaps of tib ant races. No. I think going
it's
like
not.
up hills
But
or
it's not.
upstairs.
It's not.
Why?
It's not a high tendon load.
If
Because you're contracting the muscle.
yeah, it's
And
not against body weight, I suppose. It's like open chain.
Yeah, I guess that pulls on the tendon, but we know the tendon loads are the highest when you're like for the Achilles max when the tendon's elongated.
Elongated, true.
So that's why I mean I would see more tenosynovitis. That is bowly out.
You bowled me out.
Oh, middle stump. That just come to me too. You know, we don't often get one of those. I reckon in all the episodes we've kind of agreed to disagree, but that was a clear bowl.
Yeah, you got me there.
Far out.
I was like really trying to spark a little bit of debate today too. And I was like, oh, this will get ya.
Going for it. But yeah, so I mean,
Blood supply.
Oh yeah, the blood supply. Yeah, well, the blood supply is a funny one because I learned in university that you have, or most people have that avascular area. So you've got the dorsalis pedis come down and the posterior tibial artery come down. You have the medial branch of the DP, which is the artery around the front of the foot, and that supplies the navicular. And the way that it is, you've just got this area in the middle that doesn't get much blood flow. But the first person to report this, to give him some credit, 1958, War et al. First described an avascular zone in the central one-third of the navicular. So we think we've got the part on top. Remember, that is convex, middle, side, and side. So he was the first person to describe that avascular, and it was long hypothesized to increase susceptibility to stress fractures. Less blood flow, which is really important for the bone healing. And yeah, that's what I was taught. I'm assuming that's what you were taught as well. Mm-hmm. But yeah, the end spot, and that's where you palpate. But McCune et al. Performed a cadaver study and determined that 58.8% of naviculars had no zones of avascularity. Now, I posted this on my LinkedIn and we're posting on the Instagram this week. Only 11.8% of naviculars had the classic dorsal and central zone of hypovascularity, which is no blood flow, suggesting other factors may also contribute to stress fractures. So, let's say approximate. 12% of people had that avascular. The rest, it was all over the place. Now, if you look to this paper, which is tagged in the show notes, it is such an awesome look because you see some naviculars, they're just completely covered in black, which is where they've filled the arteries up, and you can see it all over the navicular, and others where there's zones. So, anatomical variation.
That's super interesting
Yes,
because the avascularness of the navicular is one of my understanding of one of the reasons for them to be so slow to heal and for them to be so complicated and high risk. But if that's not something that is as common as we thought, then why are they still so high risk and complicated and slow to heal and all of those things?
Yeah, well, maybe the ones that are slow to heal are in that proportion. The one in, what do we say, 1 in 10 maybe, that do have a pretty poor blood flow maybe. Or
But you wouldn't know, right? Like how would you know?
No, you don't know.
Unless you go and do like an angiogram, is that what it's called?
I don't want to answer because I don't know the answer. Maybe I know what you mean, but they put the dye and stuff in.
Yeah.
But it's probably speaks to, and I think, and it is my opinion, that's what I believe is one of the reasons why the healing times are so varied and potentially the return is so varied amongst the severity of navicular stress fractures, depending on if you've got a bone stress versus displaced versus undisplaced, which are a lot more serious. But it can be from 4.8 months to 8 months.
Yeah,
it's a big variation. Difference. So you pair, you think you pair someone with, let's say, some of those biomechanical variances, maybe a really flexible foot, and they have a longer second met, and they fall into the category of having a navicular that doesn't have the greatest blood flow. Those factors alone are going to do so much to impair that healing process. Mm. But, you can't screen that and say, yep, just go and see the ortho now, get their opinion.
Yeah.
Yeah. And you pair that with the long time to diagnosis. But I thought that's something that I have learned completely different.
That's also interesting in that if there was a easier way for us to be able to work out whether someone's navicular has a good blood flow versus someone doesn't, that could really influence the weight bearing status if it was recently diagnosed. Because if it was a well vascularized area, then we might just say for them to put a boot on but continue weight bearing, and then once it's not sore with weight bearing, not sore in the boot, take the boot off. Whereas if it's more of the poor vascularized navicular, then you're probably going to be a lot more conservative with even the weight-bearing status.
My opinion is unless it's a bone stress low grade, they just need the opinion of an orthopod or a sports doc, because as you just said, those decisions you could think, the consequences of these injuries, if they're not managed properly, is just so high.
I guess also
surgery and
if it's the tensile versus compressive side of the navicular would influence that a lot too.
Yeah. I don't think it's I actually don't know the data on what the incidence of the plantar surface. It's mostly the dorsal. There is one study.
Well, so that obviously is a big reason as to why you need to go non-weight bearing.
Yeah, well, there was we'll talk about one study that we're talking about MRI versus CT, and I think that was 58 or 64 navicular stress fractures, and all of the little small fractures were in the dorsal aspect. So,
should we explain what tensile versus compression means?
Yep.
So I guess if it's on like the tensile side of a bone, then every time you load that bone, the bone's getting separated. So it just makes it a lot harder for that bone to heal. Versus if it's on the more compressive side, every time you load that bone, the bone's getting pulled together. So it's a lot easier for that bone to heal with some loading. So navicular often being stressed on the more tensile side would then mean that it probably needs to be more aggressively offloaded, because each time you load through that bone, it's going to pull the bone apart, which is going to make it hard for it to heal.
One analogy I was thinking, tell me your thoughts, first time I've said it live, if you get a pencil and you put some glue, wet glue on top of the pencil, and you put pencil, middle of the pencil, you put some glue on top and some glue on the bottom, and you bend the pencil, the glue on top, you're going to see it become further away from each other, whereas the glue underneath, you're actually going to see it come in and thicken, and that's kind of representative of what we would see with callus on bone. Does that make a bit sense conceptualized?
I couldn't work out what type of glue I was picturing.
Oh, just normal super glue.
Okay. So like PVA glue?
Yeah, PVA glue will work. So you pull it apart, and you can, because you're pulling the glue apart, it's going to run and not come together, whereas on the other side, which is the compressive side, just an easier way to conceptualize it, the glue will be being pushed together, so it will actually thicken but never be pulled apart.
Yeah.
Okay.
Because
I get the way
blue tack might be a better,
you could do blue tack,
better thing to describe, I guess.
Yeah, I like
there's just so many different types of glue.
Yeah, that's true.
Tell me about imaging. So imaging is something that I think is really interesting in these bone stress injury sites, and I want to know what the best type of imaging is, but how to best go about ordering it. Yeah,
so the imaging will speak about X-ray, CT, and MRI, and some studies recommend that as a first line, people should have just a bilateral weight bearing X-ray, and then if that's negative and you're still suspicious, that have an MRI and then a CT. But in 1992, Khan et al. Did plain radiographs on already CT confirmed stress fractures, and it was only positive in 18%, and that was 14 out of 77 people. So that's such a low number. And the reason for that is you need this osteoclastic reabsorption to occur before you're going to see those radiographical changes, which can take up to 3 weeks. So, I'm sure there is some value potentially looking for fractures and things, but if you're suspicious and you're going to be the primary management, I think looking at an X-ray, if it's in the earlier stages, probably isn't going to yield you that much. So MRI, CT, that then moves to CT is going to be pretty good for good bony detail and visualization. There's some literature to say it's good preoperatively, but again, that's not for me to look at. And there are some okay classification systems if you do use CT. But there was one study looking at called Navicular Stress Fracture Outcomes in Athletes, analysis of 62 injuries by Sextina et al. And using CT as the initial imaging modality correlated positively with the correct diagnosis of 1. In contrast, MRI, when used initially, was only 71% accurate. There's nuances with CT and MRI, so that's why, again, I think it's best to have some other people look at it. Obviously, if it's bone stress, MRI is going to be really good to detect that early bone edema and any medullary extension, which is going to be better than the CT.
Yeah, it's just surprising that an MRI doesn't even pick up, it does in 71% of cases, but that bone edema is usually the thing that you're sort of looking for, that whiteness in the MRI.
Yeah, but it might
is what
not
you
pick up like a fracture line.
So an MRI would pick up some sort of stress reaction.
Yeah, so yeah, MRI is going to be better if you're suspecting more bone stress. It's going to give a better representation, whereas CT is going to give a better representation of the fracture line, which is,
Okay, so
CT is looking
CT
at bone.
Wait, so an MRI can miss a fracture, but
Yes.
it will pick up a response.
Bone stress, generally speaking. Of course, we can't say clearly yes only, like nothing's 100%. Even in saying that, so the other study, which was in the navicular stress fracture outcomes, when they retrospectively looked at CT studies, 11% of these 60, I think it was 62 people, 64 navicular stress reactions, 11% missed. There were 6 small fractures missed, and they actually looked back on them retrospectively, plus some other fractures missed. So, Blake,
Look this up.
so let's say an MRI might not pick up all the angles of the stress fracture, but you would expect to have bony edema surrounding
Somewhere.
that.
Yeah,
So the concern is you send them for an MRI and you diagnose them as having a stress reaction and it's missed a fracture.
A fracture, yeah, but it won't. It will pick up enough to know that there is something that requires further intervention for the navicular bone.
Yes. Yeah.
Whether it be a fracture or a stress reaction, it should be able to pick up bony edema of some description.
But with these images, I don't think you can ever say, or really anything is 100%. Like if you, which would be a very, very rare scenario, but if someone has all the clinical symptoms and their imaging is clear, I think it's worth investigating, or just speak to your local ortho or sports doc. The majority of them are such nice people and good people, and they're happy to be able to have that discussion. Because again, it's just a serious injury. Now, one important differential, which is funny because I haven't mentioned this before when I've spoken about kind of bone stress, but Müller-Weiss Syndrome, which I think Nadal had. I think that was him. This is the one that he had. I'm pretty sure. So
he just retired.
Yeah, that's a differential diagnosis for navicular stress. So spontaneous adult onset osteonecrosis of navicular. Clinical symptoms can mimic navicular stress fractures. So on imaging, plain radiographs may look like a coma-shaped deformity, and depending on the stage, collapse of the navicular, it may occur bilaterally, and treatment is typically conservative with sometimes surgical management. So that's just something to be aware of.
So with Nadal, for example,
yeah,
surely his would just be...
I can look that up. Blake, look that up.
Blake, look that up. Would his not have stemmed from a navicular stress fracture, though?
I don't know if it's a prerequisite. It was Müller-Weiss Syndrome.
Cool. Oh, it's a degenerative condition.
Well, it's osteonecrosis, which is...
But that could happen if you fractured your navicular and it didn't have intervention.
Could. I don't know.
Well, tell me about your cup of tea then, the management.
Yeah. Well, the literature's pretty clear on this, and we've got some cool studies of comparing, going weight-bearing versus non-weight-bearing. So, generally speaking, it should be complete non-weight bearing for 6 weeks. And there's a bit of debate between should that be in a boot, like a cam walker, or should that be in a cast. And that, of course, as you would know, is individual to the person. If you put someone in a cast, it is going to be good in the sense of it is protective. But, which I like this, they read in the paper, for the elite athletes, they don't do that because they get calf disease. Which I like that. It makes it sound a little bit scary, which is kind of good. And what they mean by that is just atrophy and all the changes through there. So if you put someone in a boot, they can still come out and keep their ankle range of motion while not loading the navicular. So they should be as a standard, and they're usually going to be managed, in a group, in a team, but non-weight bearing for 6 weeks. And when they have compared the non-weight bearing versus weight bearing, a study 1982 by Torg, 21 patients with navicular stress fractures. In patients with non-displaced or displaced fractures, they reported excellent success with 6 weeks of cast immobilization and non-weight bearing. When they spoke about doing it the other way, so 7 patients that were treated with weight-bearing cast or earlier activity developed complications. So I've got some literature to say that if it's too early, they're gonna struggle.
Yeah, I think that's important to mention because I know that a lot of our rehab now is very criteria based rather than time frame based, but I think in bone stress injuries you are pretty obviously waiting for that bone remodeling to happen, which is quite time frame dependent.
Yeah.
And the risk of loading too early could mean that they need to have another 6 weeks, say, in a boot or non-weight bearing, opposed to if you do that in another area where they have a flare up, then you just offload it for a couple of days and get back into it. So I feel like it is an area where it's quite different.
Yeah. Another review by Carnell, 86 patients with navicular stress fractures, 86% healing with return to full activity at 5.6 months in those who were made non-weight bearing for a minimum of 6 weeks. Now, comparing that, they reported a mere 20% success in the group prescribed weight-bearing cars or less than 6 weeks non-weight bearing. So a massive difference for people that weight bear too early. So it's a decision of the person. You know, they're in a cast, they're obviously going to be less likely to load that compared to a boot because you can take that off and move around. And cool study, and it's kind of interesting because it just speaks to the nuance, but Torganell, they didn't find a difference between people getting non-surgical and surgical, but there was a trend favouring immobilisation and non-weight bearing, which is non-surgical, 96% versus 82%. But surgery cases more likely to be a little bit more sinister and severe. They might be undisplaced, they might have other risk factors involved, so you might see that number just lower anyway because the cases are just more complex that are getting surgery.
Displaced, not undisplaced?
Sorry. Displaced is when the bone comes away.
More likely to be, like, separated.
Yes, yeah. Well, those cases are going to be a bit more complex and probably harder to manage and things. So that's why potentially that is lower. Mm-hmm. Yeah. Talking about surgery, obviously that's...
Wait. I just want to go a little bit more, like, actually, how do you do that? So if you decide someone should be in a cast... You just
I wouldn't decide that. I wouldn't put someone in a cast. That'd be doc or ortho.
Okay.
You know, these cases, it's great to have input from other people and specialists. So there was another study by Malley et al. That had a systematic review of 200 navicular stress fractures and found the mean return to sport in surgically treated patients was 16.4 weeks compared to 21.7. But I couldn't find the classification of what they were because obviously it matters, the grading, like the ones that are higher grade are going to take longer. So...
But it's shorter because the higher grades then end up having surgery, which then gets them back quicker.
Yeah. Comparing on a broad scale, like population level, there doesn't seem to be a big difference. But of course, on an individual level, there are cases where people just need to have that opinion and they will definitely do better with surgery. Like the non-union rates have been reported at 20% in higher and completely displaced fractures, and some people need a revision. So, yeah, that's just something to be aware of. I've seen cases where people have had surgery for this and they do have a change in their anatomy. And sometimes you could, theorise that puts more force in an area that's trying to...
Probably increases the risk of things like osteoarthritis later in life.
Yeah, like pain and stiffness.
Any kind of trauma, I'd imagine.
Yeah.
Which you might be able to avoid if you go conservatively.
Yeah, and looking at... Which they've done some cool follow-up studies. That one we were talking about, the analysis of 62. So 7 refractures, 11.2%, occurred an average 5 years after the initial injury, predominantly in those aged less than 21, none with previous surgery. So that's interesting to think that, it's a long time. Could that have changed something in the navicular and then that put it at a higher risk? But yeah,
maybe.
One to be aware of, and we know a fair amount about it, but I think the big learnings and me diving into literature, learning more about the imaging is important, and just being a bit more suspicious if there's a clinical symptoms, getting the opinion of an ortho or a sports doc is going to be important. I can't see any cases really where it's going to be best not to have them out of a boot earlier than 6 weeks, and then your typical navicular management. And the avascularity is probably something that I've seen now and learnt to be not as common as previously thought.
Yeah, that is interesting. I think that's interesting. However, it's hard to make use of it. So you kind of have to assume that they're an avascular type, because if you're assuming that they're have a good blood flow, then you might be doing them a disservice to push them along quicker than they can.
Yeah. Season 2, first one off the books. We really are excited for what this season's going to hold.
Is season 2 going to be 109 episodes too?
Yeah, I don't know. I want to do something for 150 and 200. I want to do something in person, but it's hard because we have people all over the world. But maybe a live something now we're using a different program. We can have some people come in. That would be really cool.
That would be cool.
We'll see.
We'll see.
in a couple of weeks.